All right, let's paint a picture. Imagine a patient who keeps coming in with painful mouth sores, but then one day they develop sudden, terrifying vision loss. This is the unpredictable world of Behçet syndrome, and honestly, it's a condition that can challenge even the most experienced of us. So today, we're going to build a clinical framework to help you navigate this complex disease with confidence. All right, let's dive in. So first things first, what are we really dealing with here? At its absolute core, Behçet syndrome is a vasculitis, an inflammation of blood vessels. But it's a particularly tricky one. People call it a clinical chameleon, and for good reason, because it can attack any blood vessel of any size, anywhere in the body. Arteries, veins, you name it. And that right there, that's the key to understanding why its presentations can be so diverse and, frankly, so baffling. Here's how we're going to break it all down. We'll start with the main challenge of the disease, then lay out the guiding principles for how to manage it. After that, we'll walk through treating the most common stuff you'll see. Then we'll get into the heavy hitters, managing severe organ involvement. And finally, we'll talk about the long-term outlook for these patients. So what is the single biggest challenge? It's just how unpredictable this disease is. I mean, one patient might just have some mild oral ulcers for years, and that's it. But another could develop sight-threatening eye inflammation, and it feels like it came out of nowhere. What this really means is there's no one-size-fits-all playbook here. We have to be ready to tailor our approach for every single patient and be ready to adapt on the fly. To navigate that kind of complexity, we need a reliable guide. And for us, that's the European Alliance of Associations for Rheumatology, or EULAR. They provide what is really the gold standard framework for managing Behçet's. You should think of these principles as your compass for making really sound clinical decisions. Let's dig into these 5 core goals. Number 1, we have to be aggressive about suppressing flares. Why? Because every single flare can cause irreversible organ damage, and that is our ultimate enemy. Second, this is not a solo sport. You need a team of specialists. Third, you've got to tailor the therapy, especially for young men who often have a much more aggressive disease course. And finally, you have to be on high alert, constantly, for any eye, vessel, neurologic, or GI involvement. Those are the red flags for a much, much poorer prognosis. Okay, so now that we have our guiding principles, let's actually apply them to the stuff you're going to see most often day in and day out, the skin and mouth lesions and the arthritis. Think of this as a treatment ladder for those oral and genital ulcers. We start on the very first rung with simple topical treatments. If the ulcers just keep coming back, we climb to the next rung with oral meds like colchicine or apremilast to try and stop future outbreaks. For those really stubborn cases, we might need a short burst of systemic steroids. And for the most severe, relentless ulcers, well, that's when we have to bring out the big guns, the powerful immunosuppressants. So, at that second step, a really crucial decision is choosing between colchicine and apremilast. Colchicine is generally our first pick. It's cheap, it's usually well tolerated, and it gets to work fast. Apremilast is a really solid alternative, but it costs more, it can take up to 12 weeks to really kick in, and it's known for causing more GI side effects. So a lot of the time, the choice really just comes down to these practical things and what the patient can tolerate. And what about the arthritis? Well, fortunately, the type of non-deforming arthritis we see in Behçet's usually responds pretty well to the therapies we're already using for other symptoms. It's almost never the main reason we have to escalate treatment, and just like with the ulcers, colchicine is the first-line agent we reach for. Okay, so far, we've talked about the more manageable sides of Behçet's. But what happens when the disease goes for the eyes? What do we do when a patient's vision is literally on the line? This is where things get really serious. We're now in the territory of severe organ involvement, where every single second counts. The decisions we make here can mean the difference between sight and blindness, or even life and death. When it comes to the eye, it is a tale of 2 different uveitis. Anterior uveitis is kind of like a small fire that we can often put out with just some topical treatments. But posterior uveitis, that is a raging inferno that's threatening to burn down the entire house. It requires an immediate all-out assault with systemic immunosuppression from day 1. This is a critical distinction that you absolutely cannot afford to miss. For posterior uveitis, the game plan is a decisive 2-pronged attack. You hit it hard with high-dose systemic glucocorticoids to douse that acute inflammation, but, and this is so important, you must simultaneously add another immunosuppressive agent. The standard choice here is azathioprine. Let me be crystal clear. Glucocorticoids by themselves are not enough. Now, if our initial attack doesn't work, or if the patient shows up with a 5-alarm fire right from the start, we have to escalate. The big guns here are the TNF-alpha inhibitors, like infliximab or adalimumab. But I have to give a word of caution about cyclosporin. It can be neurotoxic. Using a drug that could harm the nervous system in a disease that already likes to attack the nervous system, well, that's a significant risk we generally want to avoid. And listen, the evidence absolutely backs up this aggressive approach. A landmark study showed that infliximab not only puts out the fire, but it actually helps rebuild the house. It dramatically reduces how often future attacks happen and can even improve vision that's already been lost. This is what we call a true game changer, a disease-modifying effect. Think of this table as your cheat sheet for other high-stakes scenarios. Do you notice the theme here? We're using powerful combinations of immunosuppressants to hit the disease hard and fast. The key takeaway is that in these situations, you have to be aggressive. You have to be proactive. Hesitating can lead to disaster. All right, we've put out the immediate fire, but the embers are still glowing. So now let's shift gears and talk about long-term management. What does the future actually hold for our patients with Behçet syndrome? The journey with Behçet's is, well, it's a roller coaster of good times and bad times. But there is a bit of a silver lining. For a lot of patients, the disease does tend to burn less intensely over time. That said, we need to be extra vigilant with young men and with anyone who develops major organ involvement, because they often face a much tougher road ahead. Let's talk numbers for a second. A major study found a 5% mortality rate over almost 8 years. Now, while that might sound low, it's a sobering reminder that this disease can be fatal. But our biggest battle, day in and day out, is against disability. We are fighting to preserve our patients' vision, their neurologic function, and their overall quality of life. Let's look at the life cycle of this disease. The early years, they're often dominated by skin, joint, and eye problems. But don't let that fool you. The most dangerous complications, like CNS and large vessel disease, can be lurking in the shadows, ready to show up years down the road. And even when the active inflammation quiets down, the scars from past battles can continue to take their toll. Okay, this is a super critical takeaway for your practice. When it comes to severe disease, you cannot let your guard down too soon. The rule of thumb is to continue treatment for at least 18 to 24 months after the patient is in remission. Tapering any earlier is like leaving the door wide open and inviting the enemy back in for another devastating attack. And that leaves us with the million-dollar question, doesn't it? In a disease that can smolder for decades, how do we know when it's truly safe to start backing off on treatment? This delicate balancing act, weighing the risks of long-term therapy against the risk of a catastrophic relapse. That right there remains one of the greatest challenges we face in managing Behçet syndrome.